Hi, I just wanted to offer some of Liz's clinical pearls for your session 2 HEENT um, work. So this specifically is more on rhinitis, and just going to talk a little bit about that or add to what you already have in your session materials. And you may have had some of this in your pharmacology course already. I'm just not aware. So wanted to address inhaled nasal corticosteroids, which are the mainstay for treatment of allergic rhinitis, also very good for treating nasal polyps, at least initially before surgical exploration is considered. There are at least two OTC nasal corticosteroids right now. One is nasacort triamcinolone. The other one is Flonase or fluticasone. Not sure how the over-the-counter availability of these agents is going to affect their use. Certainly can be more expensive for those people who have good third-party paying sources for their medication. For example, if your copay is $7 for a month's prescription, these drugs now go for as much as $27 per month for a bottle of Flonase. So not sure where that will go. Because many patients are used to the rapid action of nasal inhaled decongestants like Afrin, oftentimes they will feel that nasal inhaled corticosteroids are not effective. And so what they need to understand is that these are not PRN or as-needed drugs. It takes about 5 days for the nasal inhaled corticosteroids to reach steady state before they're going to really notice much of an effect. Sometimes they'll get a little bit of an effect beforehand, but usually that's just because of the moisture that's been added to the nasal mucosa. Let's see. One of the most frequent side effects from these nasal inhaled corticosteroids is nosebleeds. And this is because they may not be administering the nasal spray in the best way, and they're spraying it towards midline or towards the septum, when in reality what they need to do is spray it laterally towards the turbinates to really address the mucosal inflammation. So the best way to do that is to use the opposite hand to the opposite nose. So you're going to take, for example, my right hand to my left nostril and spray, and you could see that it's aimed outward towards the turbinate or towards the lateral aspect of my nose. I'm going to then take my left hand and go towards the right nostril, as opposed to people using their dominant hand and spraying. And you can see with my right hand I'm spraying to my to the medial aspect of my nose, or in the nasal septum, and that's where you're going to get most of the erosions and the bleeding caused from these medications. By the way, this is X-Clear, which has xylitol in it, and it's not a nasal inhaled corticosteroid, but this is a really good lubricant or moisturizer for the nasal mucosa too. You can get that one over the counter as well. Let's see. Sometimes people will complain of a bad taste from the nasal inhaled corticosteroids, and what they need to do is remember that the head should be tilted slightly forward when they're spraying, and not backwards, which causes the drug to run down the back of their throat. So that's what I'd like to offer you on the nasal inhaled corticosteroids. I also wanted to make sure that you were aware of the difference between vasomotor rhinitis and rhinitis medicamentosa. I'm not sure that this was clear in your lecture materials. So vasomotor rhinitis is often a non-allergic and sometimes non-infectious or non-viral inflammation of the nasal mucosa that's accompanied by clear nasal discharge. And when you see it most is when a person changes from maybe a warm room to a cool room, an air-conditioned room, and all of a sudden their nose will start to run, sometimes quite profusely. It can often happen at meal times, particularly if a person is eating spicy foods, and we see this more frequently as a patient ages. A treatment that I really like for vasomotor rhinitis is the use of ipratropium or Atrovent NS. It's another nasal spray, but it's Atrovent in the nose, and it's essentially just a drying agent. It comes in two strengths, 0.06%, which is actually used for treatment of viral rhinitis, colds and such, and then a 0.03% formulation, which is the better one to use for just plain old vasomotor rhinitis due to room temperature changes or eating. Both of them can be administered 1 to 2 sprays in each nostril 2 to 3 times per day. I will let you know that the mechanism of action is that it's a drying agent, and so it can be very drying, so overuse can cause problems, to include nose bleeding. Let's see. I then wanted to contrast that with rhinitis medicamentosa, which is caused from the prolonged overuse or use of over-the-counter nasal spray decongestants such as Afrin or Dristan. These nasal sprays work through vasoconstriction that reduces the inflammation in the nasal mucosa. The problem is, as they wear off, they can cause a rebound vasodilatation or tachyphylaxis that increases inflammation in the mucosa and then results in the patient needing or feeling like they need to use it more frequently. So where the recommendation may be to use it every 6 to 8 hours, pretty soon a patient, in order to be able to breathe through their nose because of the inflammation, they're using these sprays every 1 or 2 hours. And they really become very dependent on them in order to be able to breathe through their nose. To treat rhinitis medicamentosa can be very challenging because essentially you're telling the patient they need to stop using the nasal inhaled decongestant. They need to wean off of it. They can wean off slowly or abruptly, whatever they're willing to tolerate. In fact, sometimes the worst periods of time are through the night when they're trying to breathe through their nose and they can't. So you tell them they can use the nasal inhaled decongestant at night in one nostril. At least they can breathe out of that nostril. On alternate nights, change to the other nostril and gradually wean down. However, to treat, we often add on nasal inhaled corticosteroids. Again, remember the steady state is about 5 days before they get a full onset of that medication, and it's never going to feel the same as the nasal inhaled decongestant to them, but at least it'll give them some relief. We often, if it's a really bad case of rhinitis medicamentosa, will have to consider using oral steroids or oral decongestants if they can tolerate those things. So that's my take on some of the clinical pearls related to rhinitis, and I hope that this has been helpful for you.